So good morning to everybody. Thank you, Dr. Garrett, for putting all this together and a very important topic and very good speakers, whatever I have heard till now. Very, very informative, Dr. Deshita as well as Dr. Manpreet. So I'll be talking about both presbyopia correcting lenses as well as presby-LASIK. Since Dr. Dishita already covered most of in fact all of presbyopic correcting IOLs, I'll just quickly skip through and we'll go to presby-LASIK um, almost directly. So we know that our patients, previously when they used to come to us, they used to ask us how safe is cataract surgery. But now the focus has shifted. When they come to us, they never even talk about safety. They expect us to be doing a safe surgery. And most of the time that we spend with them is spent on what type of lens to be implanted. So it becomes very important to know about these lenses, and most of our patients now want a presbyopic treatment, whether it is in the form of a LASIK or it's in the form of IOLs for cataract surgery. So already we talked a lot about EDOF and trifocal lenses and their principles. So I think I can kind of almost skip through these. And as Dr. Dishita said, now these trifocal lenses, they have principles in which the steps are responsible for the different features of the IOLs. So this is done by altering all these lenses are playing on the step width as well as step height, and as we alter these step width and step height, we can have different focal points for different lenses. So the step height controls how the light energy is split, and the step width controls the power of the lens. So as you can see, if we increase the step width, then we decrease the power, and it starts working for intermediate vision. And if we decrease the step width, then this starts working for the near vision. And when we combine the two together, that's what our trifocal lenses are. So along with this, apodization is one feature which is important, and again it controls how your light energy is distributed. So as you decrease the uh, step height, more light goes into for distance vision, and hence you are able to give better contrast and more light for distance vision, because contrast was something that was always a concern with these type of lenses. And now we also have this panoptic lens, which is basically not just a trifocal, it's a quadrifocal lens. And this has got something which is called the Enlighten technology, in which there is another additional step created. And this additional step is responsible for dividing the light into two parts. One part goes for distance, so that there's a better contrast for distance, and the other part comes to to intermediate rather, and it shifts the intermediate from around 80 centimeters to around 60 centimeters, because this is considered as a more functional intermediate vision. So instead of 80, 60 is a better suited intermediate. So that's the principle of this lens. So this is as I said, this is called Enlighten optical technology. So talking a little about Vivity, because the principle is a little different from all other ETOFs. As again Dr. Dishita said, all these have proprietary technologies, and these are based on acrylic designs, etc. And there are again rings which are proprietary designs of companies. But in Vivity, there is an X-wave technology which consists of two smooth surface transition elements that simultaneously stretch as well as shift the wavefront, creating a continuous extended focal range. As you can see, surface transition 1 is a slightly elevated smooth plateau which stretches the wavefront, creating a continuous extended focal range. And the surface transition 2, now this is basically a small bump which is there in the center. This shifts the wavefront to utilize all the available light energy. So this diagram clearly shows how it stretches as well as shifts the wavefront, so as to give us a better quality of vision. So based on these characters, again, I'm just doing a quick review of this because I don't want to repeat the same things, but based on these characters, we decide as to which lens is most suitable for which patient. And a scientific rationale for near and intermediate distance visions is given here. So 40 to 80 centimeters is what we generally require, and 60 becomes a very, very optimal intermediate vision. So any lens which starts working between 40 and 80 becomes a lens which is useful scientifically and in practically. So coming now to press by LASIK treatments, again, there are a lot of press by LASIK treatments that are available now, but I start by saying that all current and new solutions are actually compromises, and we are still trying to find out the most suitable procedure for each patient. Monovision is what we used to work on previously, but this monovision used to result in loss of stereopsis and fusion, and all these press by LASIK treatments are basically micro monovision. Since it's a micro monovision, there is no loss of stereopsis and fusion, and there is a good contrast, and these patients are actually happy patients. We've been doing press by LASIK for the last 7 years, and now press by LASIK is becoming an accepted norm, so it's important to understand a little about this procedure. So most of these procedures work on a hybrid approach where apart from micro monovision, they create a multifocality on the cornea, and you have to choose appropriate proportion of these two methodologies according to the patient's needs, and that's how the treatment is designed. Now, press by LASIK can be central press by LASIK, peripheral press by LASIK, or a laser blended vision in various machines. And most commonly used nowadays is the central press by LASIK, because this is the most physiological. Now, there is a central hyperpositive area which is created, and this is used for near vision, whereas the peripheral cornea is used for distance vision in central press by LASIK. And this can be used for hypermetropes, myopes, as well as e-metropes. Even for e-metropes, we have done central press by LASIK. And of course, patient selection is important. But once you select your patient properly, these are happy patients because they get independent from reading glasses. So this is the principle of central press by LASIK. As you can see in the center, you can see center is reddish, and in the center we create a hyperpositive area, and there is a small bump which is created, and so this center works for near vision. And when the patient views for near, then our pupil constricts, so it's the central near zone which becomes more central 3 millimeters which becomes more active. When the patient is viewing for distance, our pupil dilates, and so it's the 3 to 6 millimeters zone which becomes more active, and in between there is a smooth transition. So none of our patients we've seen have complained of any glare and halos. Probably the reason is that here there is, though it's a multifocality on the cornea, and that was very much expected, and we were also surprised. So, but probably there is only one single ring there, and it's not a multiple rings there, and probably that's why the patients are not complaining of these problems, and they are happier patients. So it's a pupil dependent procedure. And as I said, it is more physiological, but because whenever we are reading, it's the pupil constricts and the central area becomes more active. But we have to remember that there is always a slight impact on distance vision, as some light also passes through the near zone and does not focus perfectly when the patient is viewing for distance, and hence there would be a certain amount of line loss or decreased vision for distance, which is always told to the patient. Now, it has been seen that most of these procedures will have a single line loss for distance vision, so that's why we said it's a compromise. Out of these, one procedure which works on a little different principle is the press beyond, where there is a laser blended vision. It basically plays with spherical aberrations, and there is an alteration in the spherical aberration which is responsible for near vision, and this is combined with a micro monovision. So we can skip these patient selections, etc., because I think time is over. So just a brief about how the treatment is planned. The treatment is planned such that if it's a hyperopic patient, a bilateral treatment is planned, which means that in the dominant eye, a mild or a soft treatment is done, where a plus 1.25 to plus 1.5 power is given, and in the non-dominant eye, a more regular or a standard treatment is done, which means that eye has a near vision power of around plus 2. So dominant is always made better for distance, and non-dominant is made better for near, and when the patient sees with both eyes, the patient is a happy patient for distance as well as near. In myopes, what is planned is generally unilateral treatment, which means the dominant eye is made for good for distance, and only a plain LASIK may be done, and in the non-dominant eye, regular treatment is done, so it's made good for near. So basically, the treatment is decided by doing a preoperative simulation test, and in which we put the lenses in front of the eye and we show to the patient what would be the actual effect after the procedure, and based on that we decide as to which treatment would be better, whether a unilateral or a bilateral treatment, and so that line loss is minimal, and along with that we get a good vision for both distance as well as near. So we'll skip this, but basically these were the principles of Presby LASIK, and these slides are talking about the same thing. So finally, though we don't have a perfect solution, but optics and mathematics is helping us refine these procedures further, and they are here to stay, and they are already being used for many patients. So it's important to understand them. Thank you.
Fantastic. Thanks a lot, Dr. Mohita. An important point is, you told about lenticular changes, and I think there is a concept of, I think, dysfunctional lens syndrome, where you might not evidently see lens changes, but as it's a a function of a change in aberration and that contrast. Those kind of changes start quite early at 40. So, what do you suggest? An eye trace, or even if we don't have an eye trace, how do we, decide whether you're going to do a IOL or you're going to do a presbyopia?
So even if there are early lenticular changes, we would advise a cataract surgery with one of the presbyopia correcting lenses, and better is not to go for presby LASIK. But if it's absolutely a clear lens, then it's best to go for presby LASIK. And when we go for a presby LASIK, as you already said, there is a concept of dysfunctional lens syndrome, and if we have access to eye trace, it is best to actually see how your lens is functioning and see whether presby LASIK will work or not. But if you don't have an access to eye trace, then also another thing that we are doing is we measure the aberrations, and we check how the aberrations are, because again this will affect the post-operative result, and so these two things become an important thing for assessment.
Thanks a lot. I think we've just completed our IC, overshotted by a couple of